It's Michael Fehlings, Professor of Neurosurgery at the University of Toronto, and I'm very pleased to take part in this Seattle Science Foundation update in new technologies and innovations in spine. And I'll be giving you an update on the management of a spinal cord injury to try to give you a perspective of where we've been, where are we now, and where we'll be going into the future. I don't have any relevant disclosures, but do wish to acknowledge for transparency that I've spun off a regenerative medicine biotech company, but I won't be speaking about any of those technologies in this talk today. And I just want to thank Rod and Jens for their kind invitation and for their friendship, and hope to see both of you in the near future. I always like to begin these talks by framing this around a patient that I've treated, and this is a young person, 39, who dove into shallow water in a beautiful Muskoka Lake in Ontario, sustaining this horrific C4-5 bilateral flexion distraction injury with severe cord compression, contusion at the injury site, secondary injury going right up to C2 and extending distally below the injury site. So despite the advances in early surgery and hemodynamic management, ICU rehabilitation care, this patient survived, got a level back, but continued to remain quadriplegic. And so what's our treatment approach, in the modern era? So I will be talking about neuroprotection and specifically the important role of early decompression, even in patients with an ASIA-A cervical injury. I'll be talking about some emerging strategies in the post-methylprednisolone era, and I'll be talking about machine learning and big data approaches to handle the heterogeneity of outcome prediction, which is one of the big challenges we face. And I'll be referencing some novel neuroprotective and neuroregenerative approaches, including cellular therapies, anti-inhibitory agents, and bioengineered scaffolds. And then I'll be briefly referencing some of the exciting emerging work related to the bypass of intraneural circuits through epidural stimulation and brain-spinal cord interfaces. So early neuroprotection mitigates secondary injury mechanisms and enhances outcomes. And this is really the guiding principle. And I've referenced this as time is spine. This forms the backbone to a multi-pronged approach to spinal cord injury care. So there's a strong pathophysiologic rationale to consider early surgery. And the concept here is to try to limit the evolution of secondary injury by optimizing the milieu for recovery. This is supported by strong preclinical basic science evidence, and this is really what stimulated our work well over a decade ago that culminated in the Staskis study. This was still the largest prospective study that has been done in spinal cord injury. 6 centers in North America through the Spine Trauma Study Group. And we found that in patients who are operated on in a median time of 14 hours after injury, but within 24 hours after injury, there is a 3-fold higher odds ratio of having a 2 or more grade change in the Asia Impairment Scale with early surgery. So this was a game changer, and this has had a profound impact on the influence of surgical management. So this resulted in the first clinical practice guideline, and the preferred option that was articulated was that patients should undergo early surgery within 24 hours. But the level of evidence following the rigorous grade criteria was still felt to be a bit on the low side. And this stimulated us to undertake this large prospective meta-analysis of over 1,500 of patients. This was published 2 years ago in the Lancet Neurology. And this provided very strong quantitative evidence for the concept of time is spine. So here are 2 of the figures from this paper. So on the left, we are looking at the changes in motor function as a function of time following decompression. And the red dotted line is 24 hours. We see a steep dose-response relationship in the first 24 hours. So this really highlights the importance of timing. These are the changes in neurological function that occur as a function of time post-decompression. The red line again is 24 hours. We see that this is clustered in the first 24 hours. So what are the next steps in this concept of time is spine? So one of the first priorities relates to knowledge translation, and we will be updating the guidelines. And I'll give you a hint of some of the data that will be published later this year in the Global Spine Journal. There's a lot of interest in the role of ultra-early surgical decompression, potentially considering the role of expansile duroplasty. And I think that techniques such as intraoperative ultrasound can play a role in terms of guiding the extent of decompression. Through the Global Spine Journal and the AO, and also with the support of Praxis, we will be issuing a new set of practice guidelines later this year. And there are three topics that we'll look at. One is the role and timing of surgery in acute spinal cord injury. This will be an update from the 2017 guidelines. And essentially, this will be a stronger recommendation related to early surgery within the first 24 hours. There'll be some further guidance on optimal hemodynamic management of acute spinal cord injury. And will also be a guideline and care pathways related to the prevention, diagnosis, and management of intraoperative spinal cord injury. So for sake of time, I'll only briefly talk about the first topic. So here are now quantitative forest plots related to the outcomes at 6 months and at 12 months with varying times of surgical decompression. We see that early surgery, defined as within 24 hours, is associated with very large changes in neurological function. So these are logarithmic plots. And again, we see odds ratios of around threefold higher rates of 2 or more Asia grade improvement with early surgical intervention. Very strong support for this. The administrators will like this. Hospital length of stay favors early surgery, so it's actually cost effective, improves quality of care. When we first started looking at early surgery, there were concerns that we might do this at the cost of higher rates of morbidity and mortality. In fact, the opposite trend is true. There's no statistically significant impact, but we see that it narrowly misses significance to having reduced rates of mortality and morbidity. So time is spine. So where are we going now with this? And here are some pictorial representations of the traditional neurological techniques to classify incomplete spinal cord injury. And these techniques remain valid. So assessing central cord syndrome, anterior cord syndrome, Brown-Séquard syndrome, posterior cord syndrome. But the reality is that these techniques really don't even begin to describe the complexity and the heterogeneity of the patients that we see. So here's a graph. It looks like a snowstorm in January in Toronto. And what we've done here is we've graphed out the outcomes of patients with cervical cord injury, all of whom have an incomplete injury. And we see that there's a hugely heterogeneous trajectory of outcome and course of recovery. So it's very challenging to predict outcomes. And you can imagine the challenges in terms of trying to run a clinical trial with this challenge. So what we've done is we've taken a big data approach to try to get a better handle on this. We've combined 4 large prospective registries and used a machine learning technique called group-based modeling. And in this approach, you model outcomes and you cluster different variables, not just one variable. And you can develop very simple, clinically relevant techniques. So I'll present this in table form, and it's a bit of a busy table, but I've highlighted some of the key points in red, and then I'll show you this in pictorial form. So here we are able to segregate 3 groups: moderate recovery, good recovery, and excellent outcome. So we see again that the Asia grade plays a big role in terms of these different outcomes, as does the neurological level. Interestingly, central cord syndrome is irrelevant in predicting outcomes. It's really the severity of the injury. And early surgery is clustered in the groups with good and excellent outcomes. Again, validating the impact of early surgical intervention. And it turns out that to enhance the assessment of the profiles of recovery, all you need to do is to look at the neurological level, the Asia impairment scale grade, and the age. And if you add these 2 variables to Asia grade, here's what occurs. So here's the unfiltered plot. And now we can segregate 4 different trajectories: poor outcome, moderate, good, and excellent outcomes. And this is what the mean and 95% confidence intervals look like. And so very clean data prediction, and you can see that clinically this could be quite helpful in terms of assessing where a patient's going to be going. And if you're modeling clinical trials, this could potentially be a game changer in terms of altered statistical techniques. So we think this has huge prognostic relevance, and there's all kinds of new efforts underway to examine this. And this work was published last year in J Neurotrauma as part of the PhD work of my student Jatan Badiwala, who is now a young neurosurgeon coming back to Toronto after his fellowship here at the Cleveland Clinic. This was also published separately in Annals of Neurology last year, and here we were modeling a recovery in Asia A, traumatic cervical cord injury. So what's emerging? And the strategies in brackets have been tried and haven't worked. I won't talk too much about hypothermia. This is under study right now at the Miami Project to Cure Paralysis. And we'll await the results of those studies. But I will talk to you briefly about riluzole, which is a sodium glutamate antagonist. In a sense, this is repurposing of an existing drug, which is used to attenuate the course of neurodegeneration in ALS. So we've put together a video to give you a sense of what we're looking at. So in the RISCUS trial, we've been assessing patients with cervical cord injury. And here I've modeled this as a subaxial burst fracture. So we see the expansion of the primary injury through mechanisms of secondary injury. At the microstructural level, here we have the nerve fibers, the nodes of Ranvier, and clusters of sodium channels. So sodium goes into the nerve cells. It goes along with water. The cells swell. Calcium builds up into the cells through the sodium-calcium exchanger. And then there's a pathologic release of glutamate. And this sets in motion the classic mechanisms of excitatory cell injury. So how we've been applying this. So in the RISCUS trial, we were examining patients with cervical cord injury, and the patients all underwent early surgical intervention as per the STASCIS protocol and the AO spine guidelines. And as we see in this video, riluzole blocks the sodium channels and prevents sodium from entering, and also blocks this pathologic release of glutamate. So prior to undertaking a large phase 3 randomized trial, we undertook this phase 1, phase 2A matched comparison cohort study in 72 patients, 36 with riluzole, 36 controls. We found significantly improved rates of conversion in the Asia Impairment Scale grade and a significant improvement in trajectory of motor recovery. For example, here we've plotted this out for cervical cord injury patients. So we launched the RISCUS trial. This was the largest randomized controlled trial in spinal cord injury in 3 decades. And unfortunately, we ran into the COVID pandemic. The trial had to be halted, but we did enroll 193 patients. And I will give you a sneak preview of one snippet of the data. So here we are. So here are the data for all patients, and a pre-planned subset analysis was undertaken for each of the Asia subgrades, and I'll show you the Asia C results. So these are the means and 95% confidence intervals, and you'll see that for the motor scores, we narrowly miss statistical significance. We see a very interesting improvements in neurological recovery with a p-value of 0.1. But for the Asia C patients, we saw statistically significant and quite marked changes, quite large changes in motor recovery in these patients. And we also saw significant recovery in the Asia B and the Asia A subsets of patients. So this is now being put together for publication. And I think that this could be of interest to clinicians in clinical trials guidelines groups, given the lack of existing neuroprotective treatments for spinal cord injury and the fact that spinal cord injury is a devastating orphan condition. So where are we with neuroregeneration? And here's a histopathological image of a chronically injured spinal cord with cavitation, the surrounding perilesional scars. So this is a hostile cellular environment, and clearly regenerative strategies are critical to target these barriers. So what about cellular therapies? And various cell sources have been tested, and I'll talk briefly about 3 types. Neural stem cells, which are really the endogenous building block in the central nervous system. Schwann cells are being examined again at the Miami Project to cure paralysis, and there's increasing interest in the activation of endogenous stem cells. So our experience with exogenous neural stem cells was summarized in the Lancet Neurology a couple of years ago, and this is work that I collaborated on with Armin Kurt's group. And in essence, we showed that neural stem cells were feasible, they were safe, but they were associated with quite modest degrees of neurological recovery. And essentially, the take-home message was that we needed better cells, and we needed better ways to target the right cell for the right patient. And this is now stimulating the work of our group and others. So, for example, this is work recently published in Science Translational Medicine, where we were able to genetically engineer these neural stem cells to drive the expression of a growth factor called glial-derived neurotrophic factor. And when we do this, we dramatically enhance the ability of these cells to integrate into the injured tissue and to promote neurological recovery. And then one can potentially harness the regenerative potential of endogenous stem cells. This is work we published in Cell Stem Cell about 15 years ago, suggesting that the center of the spinal cord may be central to its repair. This is work from Jonas Friesen and Karolinska, showing that work by activating a latent genetic program for these dependable neural stem cells led to improved recovery, and potentially novel pharmacological strategies could be used to modulate the enhanced proliferation of these cells. So what else is going on? This is work from the EMSCI network in Europe by Armin Kurt, translating Martin Schwab's discovery of no-go-A. And here, these investigators were using monoclonal antibodies introduced into intrathecal space to try to enhance the recovery of patients with severe cord injury. And we anticipate the results of this will be available later this year. Repulsive guidance molecule A, or RGMA, is an inhibitory molecule that's upregulated after spinal cord injury. And AbbVie Pharmaceuticals and Mitsubishi Pharmaceuticals are independently sponsoring clinical trials looking at monoclonal antibodies to target this molecule. This is work that was recently completed in patients with thoracic Asia A spinal cord injuries. These are neurospinal scaffolds, the work of Bob Langer from MIT. So very cool work, and the idea to try to bridge these severe lesions, and the trial has been closed and will await the results of that initial phase study later this year. And exciting work from the United States, from Edgerton and Harkema, and from Europe, from Gregoire Courtine, is emerging related to the use of brain-spinal cord interfaces, as well as epidural stimulation to promote recovery. So where are we now and where are we going? So in 2023, time is spine. Early surgery for spinal cord injury is going to be the way to go as soon as possible, but certainly within 24 hours. Hemodynamic optimization is important, but is this target correct in all cases? What's the duration of treatment? And further work needs to be done here. Methylprednisolone remains an option, especially for cervical injuries and patients without significant medical comorbidities, but other neuroprotective options are emerging, and I think riluzole is potentially a very interesting option to consider. Active targeted rehabilitation with or without electrical stimulation is increasingly playing an important role, but deserves further study. Where are we going to be 10 years from now? I hope to see that early surgical intervention for spinal cord injury will become the international standard of care, and optimal techniques such as the potential use of neuroplasty will need to be tested and validated. I hope that several neuroprotective options will be validated, and increasingly, I see that we'll be using personalized approaches to individualized care. So, for example, examining genetic signatures such as ApoE4. I envision that we'll have techniques to assess cord perfusion and to optimize hemodynamic management of spinal cord injury. And I'm hopeful that a number of regenerative options will be studied and potentially available. And I see further advances occurring in the application of electrical stimulation and brain-computer interfaces to augment advanced approaches for targeted rehabilitation. And on that note, I'd like to close, and I'm happy to take questions.
So thank you both lecturers. That was an outstanding juxtaposition, and there was no duplication. There was enhancement, if at all, in my view. So thank you to John, and thank you for Michael. Michael, are you live again? And we had to pre-tape you, and that was so cool that we had you pre-taped. And I know he's going to his resident graduation right now. So I want to go back.
Yes, I can hear you.
Good. So I want to go back to the case that John Dymar showed before, that hurricane victim, a 16-year-old girl or so with a horrible C3, 4, 5, I don't even know what to call that, fracture dislocation.
It was all disrupted.
Yeah, it was one of those, I think.
Young, had a big canal, very flexible.
So here the question is, we want to do everything possible. The old question is, should this patient go to a specialized center and we lose critical 8 hours, or should any center try to just realign her and maybe do something on her? I'll start with you, Michael, and then I'll end up with John because he obviously took care of her. So what should we do in terms of management of disease care? Should this patient get a local care in whatever, a level 3 regional center where there's a spine surgeon present?
I think it really kind of depends on the logistics and the local expertise. So one has to balance, the timing of intervention, but the specialized expertise that is there. I would say, if I look at this kind of in the Canadian context where we've got large distances, it's optimized in the Canadian situation to transfer patients to a specialized center. And even if it involves a few hours of delay in the management, the expertise in the specialized center would, I think, would make it, worthwhile.
Now, John, you made a miracle happen in your center. This beautiful care. How long was the actual care in terms of injury to landing in your center?
About 6 hours.
So was it
flew her by helicopter. It took less than 2 hours. They prepped her in the ER, trauma saw her, cleared her, and we took her right to surgery, 6-7 hours.
How well does that work now to have maps raised in the field, the mean arterial pressure? So do you have any input on the immediate emergent care? Is there a central control system that basically informs you, or statewide standards?
Well, I do not believe we have 2 level 1 trauma centers in Kentucky, and we're really the only one's kind of like 1.5, level 1.5. Because they're football rivals. But anyway, we don't have a set state standard, but in this particular case, I know that the anesthesiologist would keep her maps up basically from the ER onto the table and throughout the surgery. And she was actually done at the pediatric hospital because it's a level 1 trauma center now too. And she was taken immediately to surgery and stabilized and decompressed and fixed. And now you could say, gee, she was an Asia B. There's a pretty good chance she's going to go to Asia C or D anyway, because that's a lot of times what happens once you stabilize them. But we like to think that we're doing better by doing things faster.
So in a nutshell, this is a patient who, as I remember, had a pretty lengthy cord signal change. I think it's like 1.5 vertebral bodies, so 2 levels, yeah. So what about how many levels to do posteriorly, anterior versus posterior? I mean, when I look at Bijan's work, and again, Michael reflected on that earlier, these long cord injuries, should we do just posterior right off the bat and do an elective durotomy and multi-level posterior fusion?
The case, she was stable. She was just had ligamentous injury, interspinous, and fracturing of the lamina over those 3 levels, but we were able to get kind of a skip fixation that we had pretty good stabilization. We did not want to fuse her long because she's so young. A lot of people might have gone C2 to C7 or something along that line, but we got pretty good fixation. She's young, had good bone. You could almost do this unilaterally and put her in a halo or put her in a brace, and she did fine, and just did a central type decompression and opened up the canal, and she got better, and so that's how we did her. Maybe we lucked out.
So now the steroid question. Did you give her steroids?
She did get steroids.
Yeah. Michael.
Because of that 5-point rule. We also did her brother the next day. He had a T12 fracture and was Asia D, almost E, just had some transient paresthesia, little perineal stuff. So we waited. She came in at like 12. And we did him the next day at like in the morning. It was actually my partner, Dr. Crawford, and myself did he did the neck and I did the back, and he got all better too. So, and we never saw him again.
Wow. So, Michael, in the hypothetical situation, this is assume 16-year-old girl. I don't know whether you saw the images well enough, but a pretty ugly AO type C injury, somewhere between C3 and C5/6. What would you have done in Canada? Would you have given her steroids in this setting? I mean, she's an Asia B.
I would have given her corticosteroids. So she's got an incomplete cervical injury. Young person will tolerate this well, and I think the 5-point motor recovery in a cervical patient, is worth the very small increased risk of wound infection and thromboembolic risk.
And would you have taken her anteriorly? The images are not available right now, but it was a pretty ugly injury. Theoretically, you could say I can do a ACDF C3 to 5 and then reevaluate her and do a posteriorly, or would you have gone posteriorly right off the bat?
I'd have to look at the images again. I mean, she was managed quite nicely. It sounds like she had kind of a reducible type of type of an injury, and I think I probably would have managed this all posteriorly. And then one of the techniques that one can use intraoperatively as well, which I'm using more and more, is intraoperative ultrasound to assess the extent of the decompression.
I think you were at the same session. You and your group, the AO Spine Knowledge from a Spinal Cord Injury, showed some amazing pictures of intraoperative ultrasound, which again leads me towards thinking for C-spines, should we be more aggressive in primarily going posteriorly and doing a very comprehensive decompression rostrally and caudally and a way more elaborate fixation than was very elegantly done in John's case. So ultrasound, intraoperative ultrasound, is that something you've used? And intraoperative intentional durotomy?
Trey did the girl, and I did the boy. He did not use it. We do not use intraoperative ultrasound yet.
Yeah, we just got new probes here, and I'll use it more after this last meeting. This is what I've learned in meetings.
We're trying to get it mainly to look for, not so much for this kind of case, but to look for disc and retained fragments in a burst fracture, stuff like that.
Yeah, the pictures that I think Brian Kwan showed were quite convincing in terms of showing cord perfusion. Michael, intraoperative ultrasound routine use, and is this at all applicable in the front, like in a corpectomy, or is it more posterior procedure?
There are new ultrasound probes that are becoming available. So I'd say a few years ago, the intraoperative ultrasound was really restricted to the posterior use, but there's now small MIS probes and small probes that you can actually use through an ACDF. And you get pretty good images. So for example, even after an ACDF, you can actually examine the nerve root. So it's very cool what's emerging, and the learning curve is very short, very easy to apply. So the images with some of the newer technology units, as what we showed at the AO Spine meeting recently in Prague, are really quite remarkable. And you get resolution of the cord parenchyma that is actually superior to an MRI. So it's really cool.
So in terms of acute intentional durotomies, are we there? Are there certain cord injury patterns like the fusiform swelling in a congenital stenosis patient where we should consider doing that here and now, or is that still something very diffuse and we should wait and see? I want to hear both of your opinions.
I haven't been doing it. And I think one of the reasons that I haven't been doing this is that I've kind of been an early proponent of kind of wide decompression. So for the bilateral facet dislocations, I often would manage these both combined front and back with a wide decompression posteriorly. And then also I've been kind of an early adopter of ultrasound, which I found is very helpful. And so, I mean, there's currently a trial that's going on in the UK by Marius Papadopoulos at the Royal London, looking at the role of duroplasty. I would say right now it's an investigational technique. What I would encourage the surgeons in the audience and attending the meeting to consider is the use of intraoperative ultrasound. It's a very straightforward technique to learn. It's very easy, very safe to use, and it gives you a really good idea. As John Dimer was indicating, say you're doing a burst fracture, and you're wondering, gee, do I have enough decompression just with the laminectomy? Has it come back enough? Do I need to go transradicular and try to take some of the fragments away or whatever? It gives you a readout right away. And you can actually use the ultrasound even if you wanted to. You can actually visualize your instruments into your fecal sac, and so it's quite an elegant technique. So I think that's maybe one of the take-home messages that I would do. I would say right now I'm not sure that I would advocate that people should start doing durotomies. To be honest with you, we'll have to see kind of what the data show coming out of the UK.
John, any repartee elective duroplasties in these acute trauma situations? Fusiform cord swelling?
No, we're not. I can tell you that in another life, doing a lot of basic science cord research, you hit that cord and bruise it with a weight drop, and you can watch it swell right under your eyes, and you get to see the dura 10 up. So there's no question that there's some compression from that dura. It's just a question of how much of a pathological problem it is that would warrant you doing that on every patient versus a selected patients versus no patient. You'd have to run a study, and it would be a great study to do in the lab to do, if they haven't done already, to no and yes, partial, and then, and just see exactly what kind of contusion you would need to justify doing that. But it would, to me, be difficult to close the dura and everything. You probably have to drop a subarachnoid drain in or something after you do
duroplasty.
Duroplasty, don't you think, Ganesh?
Yeah, I would. Is this on? I would worry about there being a risk of possible arachnoiditis as well in response to the suture lines, which is another consideration.
When you go in on these, we all know it's like somebody dropped a hand grenade in there a lot of times. It's such a mess.
So one question right here from Dr. Bott. I appreciate that. Severe bradycardia, severe neurogenic shock. Are we any further in that? Do we now know which pressors to use and how long? So you talked about MAPS, John?
I'm not an anesthesiologist. I know what to use, but they don't seem to have any trouble getting the pressures up.
Michael, there's still a lot of controversy. We had Brian Kwan lecture about not too long ago which pressors to use and how long.
Yeah, so we actually just looked at this through the AO Spine guidelines, and I think from an evidence perspective, we weren't really able to strongly advocate, Levophed over dopamine over phenylephrine. I can tell you what I use in general, and what I think most anesthesiologists are using now in intensivists, which is norepinephrine or Levophed, because it's got kind of a mixed alpha and beta activity. So I think that's probably, a good choice. But I think that, you want to work with your intensivist or your anesthesiologist, and they should use what they're comfortable with, to be honest with you. And I think that, there are pros and cons to all of them. We happen to use norepinephrine a fair bit in Toronto.
Well, this is a personal highlight to have both of you. We have to kind of conclude. Unfortunately, I could carry on for several more hours, and there's several questions coming in. But thank you both, John and Michael, for a great session and talking about cord injuries. And I saw a lot of inspiration for the future, but also take-home messages that are plausible for my practice. Ganesh, agree?
I fully agree. I just have to, as a young attending surgeon, I just have to say a big word of gratitude to Dr. Fehlings, Dr. Dimer, and Dr. Chapman for not only leading the charge in terms of guideline development, pulling together the epidemiology and our understanding from a population-based level, but also really incorporating elements of science so that we can think about these next chapters. It's really amazing and wonderful to see and inspiring.
Gary's at the door.
Thank you so much.
Thank you, Michael. Enjoy your graduation.
Take care. Bye-bye. Bye-bye.
Last lab station. Gary is here. He wants to get out of here. So we have Dr. Oskuyan and a special assistant. Can we switch to the